There are still people joining. All right, I guess we can start. Good evening, everybody. Welcome to tonight's EEL webinar. Tonight's topic is not only interesting, but also very challenging. So we'll be discussing about parametrectomy for deep endometriosis with a focus on functional outcomes and complications. Our moderator tonight is going to be Professor Mikkel Seyer-Hansen from Denmark. Our speaker, Manuel Maria Ianieri from Olbia and Rome, Italy. Before starting, I'd like to thank our sponsor, Gedeon Richter. Please allow me to share a short video with you, and then we can start.
What does it take to make a medicine? You need to shift your perspective to see success comes from a series of innovations. Without the dedicated work of our highly trained researchers, no such progress would be possible. It is today that experts need to think about the diseases of tomorrow, and premium quality requires the latest technology. All these aspects come together to create new treatments that will improve the health of millions. This is what we work for every day. Gedeon Richter, health is our mission. What does it take to make a...
Okay. Now it's my pleasure to introduce our moderator this evening, Professor Mikkel Seyer-Hansen. He's a consultant since March 2008, dealing exclusively with endometriosis at the Aarhus University Hospital in Denmark, which is the second biggest city in Denmark. He is since 2009 assistant professor at the Aarhus University, certified expert in endometriosis since 2011, and also a level 3 certified endometriosis specialist by the International Society of Neuropelviology. He has a research collaboration with Professor Horace Roman from Bordeaux, France, on the subject of bowel endometriosis, research collaboration with Dr. Gunther de Wind from the University Clinic in Antwerp in Belgium on the subject of surgical training, and continuous exchange of ideas concerning surgical techniques and innovations with other colleagues such as Horace Roman, Jörg Eckstein, Mario Malzoni, Gernot Hudelist, and Gabi Moawad. He's also having lots of PhD students in the field of endometriosis and surgical training. Mikkel, we're very happy to have you with us this evening.
Thank you very much, Erling. Too many nice words. I think I will introduce Manuel Ianieri, who is a medical doctor and a PhD who was, I think you can call, trained in Negra in close to Verona. I worked there as a consultant for 4 years with both endometriosis, but also with the International School of Surgical Anatomy. So he's probably very good in anatomy. Then you've been 4 years working with both, I think, oncology and endometriosis in Gemelli in Rome. And the last 18 months, you've been at the Marta Olbia Hospital in Sardinia. And I just checked you on PubMed today. You have a lot of recent publications regarding advanced endometriosis, both diagnosis and operation. So we are looking forward to hear your presentation, Manuel.
Thank you for the introduction, Mikkel. A few seconds to thank Salin Konstantin for the invitation, and obviously the president of the European Endometriosis League, Mohamed Mabrouk, and the past president, Tarek Krentel. Mohamed know me since I was a resident, so for me it's a great pleasure to stay with us this evening. So it's a great pleasure to talk about parametric endometriosis. That is the topic of many years of clinical research and study in my department. So it's not easy, but I try to talk about the story of parametric endometriosis that born from my doubts, and the two doubts born with the two questions. The first question is, are you sure that we are talking the same language? If you try to define parametrectomy, I'm sure that in a room with 10 surgeons, we have almost 3, 4, 5 definitions that are totally different of parameter. The scientific literature showed that also in oncology, there are a little bit of different in the definition of a lateral parametrectomy, dorsal or posterior parametrectomy, and anterior parametrectomy. So probably one of the doubts that I have for many, many years, born from the different language that we use during our presentation, our paper, and our live surgery. But another kind of doubts born from the different of the publication data of many authors. Why so different the result of the paper of Roman compared to the result of Ceccaroni, compared to the result of Mohammed or other skilled surgeon? So could depend by technical skills, could depend on surgical technique. Are we sure? So start directly on the functional outcome. This is a panorama of the scientific paper actually published. So we focalize on the post-voiding dysfunction. And what we see is that we have a large amount of data about the post-voiding dysfunction that goes to the 36% of required self-catheterization after parametrectomy, to the 6.5%, and there are 1 or 2 papers that have a complication that are this kind of complication in 0 and 0.5%. But in my opinion, is not really true. So I decided to take this author to study and talk about this kind of complication. We have a paper that is that I suggest you to read. It is Ballester from 2014, in which after the parametrectomy, we have 36% of required self-catheterization. But what is interesting is that Ballester don't talk about parametrectomy. He talk about excision of the extrapserosa pelvic fascia. That is the part, is an amount of fascia that is close to the parietal pelvic fascia and the visceral pelvic fascia, and represent the parametrium. I want to show you the data of an historical paper of the Neger team, in which the required self-catheterization was in 32% of patients. Passing through a study of Mohamed Mabrouk, in which reported in patient with an parametric endometriosis, the needle for self-catheterization in 6.5%. And to go to the paper of Roman of 2022, in which the incidence of self-catheterization go to 17%. I want to report also the experience of another kind of Italian surgeon, that is Stefano Uccella, that report 11%. But what is interesting is that also in this paper, we don't have a clear definition of the parametrectomy. It talks about the excision of a certain degree of lateral compartment filtration, but we haven't a clear definition of parametria and parametrectomy. And we finish reporting the incidence of self-catheterization in the first study that we published with a group of Professor Scambia in 2021, in which we compare a group of patients with parametrial endometriosis and a group of with a patient without parametrial endometriosis, but endometriosis in the middle compartment, in which we found that the patient underwent to parametrectomy have the 8.7% of self-catheterization for 1 month. But another kind of evaluation of the functional outcomes overall the urinary function is studied by BFLUTS. BFLUTS is a questionnaire that comprises less than 20 questions, in which the sum of the question provide a total score ranging from 0 to 45, where higher score correspond to an increased bladder dysfunction. Also in this case, we don't have a superimposed result between the author. In our experience, we reported a significant improvement of the urinary function after surgery evaluated with the BFLUTS, obviously after parametrectomy. But the Ballester, in a study that we published before the first one, the one that we see, did not detect any impact of the surgery on the BFLUTS questionnaire that represent the urinary function. The last paper that analyzed this kind of complication come from Latersen, 2022, in which he described a bladder function improved, but not with the BFLUTS questionnaire, but with the urinary test, evaluated with the complete urinary test. About the bowel function and functional outcome, obviously also in this case, usually in the literature, we use two kinds of questionnaire, the KESS and the Jiggly. Measure is the score of the Jiggly questionnaire, represent the best quality life score from the point of view of gastrointestinal function. Instead, the KESS score that is superior to 10 points represent constipation patient. So a worst outcome. In our first study, we reported a significant improvement, but is not the same for the others. For example, in a published paper in the 2020 of the Davon-Fordinia, only the Jiggly have demonstrated an improvement of gastrointestinal function, but was not the same for the KESS and the other kind of questionnaire usual for bowel function impairment. Spagnolo, many years ago, don't use this kind of questionnaire, but propose an evaluation with sensory, with a manometry, anorectal manometry, and not find different between patient underwent to parametral endometriosis resection and bowel resection. So in this scenario, I decided to study better, and I try to understand why we have so many different. So we start with this paper, and what is interesting, in my opinion, is not the incidence of post-operative post-voiding dysfunction, but what is more important, in my opinion, is this: for the first time, we try to understand the post-surgical sexual dysfunction. In fact, in this case, we have an improvement of dyspareunia, but with a higher risk of sexual dysfunction for the patient underwent to parametrectomy. And why? Probably because the injury or the coagulation or the resection of the branch of the vaginal vessel and the branch of the nervous system, that the somatosensitive system that run near the vaginal vessel, led to a worst outcome about lubrication or sexual arousability. Then, after the publication of this paper, in which we compare the outcome of patients that went to parametrectomy for DA versus patient without parametral endometriosis, we see that result. After this paper, we try to understand if we have some different in patient that was underwent to modifying nerve-sparing radical hysterectomy for parametral deep endometriosis. And what we see is that the bladder voiding deficit passed from 8% to 13%. but the post-operative sexual dysfunction remain a characteristic of this kind of surgery. Then, during a paper in which we present our technique of ureteral cystostomy and round ligament blade breaching, we study also in this case the post-operative complication. Was not focused on this kind of outcome, but we see that the post-voiding urinary retention passed to 13% to 22%. Seems obviously, but we have truly data that underline the limit between a parametrectomy in which we have a low risk of post-voiding deficit or low risk of functional outcome and high risk. So I ask and I try to overthinking about the parametrectomy for DA because I have 3 papers published with 3 different results. So I try to understand why. And I try to start with the definition of parametrectomy. What does it mean exactly? Because if we try to understand if there are some difference in this image, obviously, I have in the first one nodule on the obturator nerve. In the second one, a nodule over the lumbosacral trunks, over the pelvic wall. In the right picture, I see the right ureter totally involved in a parametral nodule. So this kind of surgery is for parametral endometriosis. But also in this case, I can explain and I can write a paper in which I describe my parametrectomy, but I have another kind of picture. I have a nodule on the uterosacral ligament with probably an infiltration of the uterine artery or a part of the lateral parameter. But also in this case, I can discuss, I can use the term parametral endometriosis. But I can use parametrectomy and the word parametral endometriosis also in this case, in which I have a parametral mass that is endometriosis with a canceroid focus, in which I see the mass that reach the hypogastric fascia. So it's lateral and deeper. But I can, if I try to ask to my resident if this is endometriosis of the parametra, probably respond me that also in this case, we have a parametral endometriosis because we have a nodule on the uterosacral ligament, and the uterosacral ligament is the cranial part of posterior parameter. So we decide to publish and study the definition of parametrectomy with the Professor Denis Kerlet that give us a really help about this issue. Lateral parametrum and paracervix, at the end of this consensus, we decide that are synonymous, but we decide not arbitrarily, but comparing the result of several studies. In addition, we have a consensus on the fact that the lateral part of the paracervix is not ligamentous structure and is made of vessel and lymph node. The dorsal parametrum that we can also name it with a rectal pill include the uterosacral ligament and the rectovaginal ligament. Don't forget this, the definition of dorsal parametrum. But the ventral parametrum is probably for me is really difficult because I spend a lot of time and years to understand exactly what does it mean, the ventral parametrum, and how can approach it. But the ventral parametrum is referred to the bladder pillar. That is a complex structure which encompasses the vesicouterine ligament cranially, the vesicovaginal ligament caudally, vesical venous plexus, that is the lateral and medial vesicovaginal veins that also known as the middle and inferior vesical veins, and obviously by the bladder branch, by the ureter and the lateral vesical ligament. But we are talking about different places in the pelvis, or we are using different language. because I tried to take two paper to estimate surgeon, but overall anatomist. With the paper of Ceccaroni, he described the posterior parametrum as composed by uterus sacral ligament plus rectovaginal ligament, that is our definition in the consensus with Denis Kerley, plus the lateral ligament of the rectum. So it's different compared to our definition and the definition with the other side. Hercule, that is with this kind of paper, that is a milestone, in my opinion, define the tissue crossing open the ureter with the parametrum. Whereas those that cross the part that cross below the ureter are to be considered paracervix. That is completely different from our definition, in which lateral parametrum and paracervix are synonymous. We change authors, and we see that with the opinion of Alfredo Hercule, lateral parametrum is the part that crossing over ureter. The paracervix are the below part. So with this panoramica and this scenario of the literature in which I didn't understand really what does it mean parametrectomy, I tried to draw a study that starts since September 2020 to June 2023, in which we try to define the parametrum, but overall the parametrectomy. Because actually the problem about this kind of surgery is that we have too many definitions, too many different results of different surgeons, in which is truly different, compare my data with the data of other surgeons. So we choose talking about and dissect cadaver with Denis Kerley, Alfredo Hercule, and Vito Chiantera. We took the anatomical landmark that could be useful for this kind of classification. And we decided to use the middle rectal artery that is present in more than 19% of the studied cadaveric dissection. And is the landmark between the part of the posterolateral parametrum, vascular compartment, neural compartment. Under the middle rectal artery, we see the part of the inferior hypogastric plexus that go to the rectum. Then the other landmarks is the fascia hypogastrica sacralis, that is a part of the parietal endopelvic fascia that cover the piriform muscle. And then the third anatomical landmark is the persacral fascia, that is a part of extrasersal pelvic fascia that go, I remember it to you, between the pelvic parietal fascia and the visceral pelvic fascia. This is the picture that we used to describe in our paper this kind of landmark. Is obviously a summary, and but is useful to understand the four classes of parametrectomy. The first one is the superficial parametrectomy, in which we stay medial to the persacral fascia and cranial to the medial rectal artery. The class 2, that is the type 1 deep parametrectomy or DP1, is a parametrectomy in which one of the two landmarks are overcome during the surgery. And in DP1, the tissue excision go lateral to the persacral fascia. When go caudal to the medial rectal artery, we have a deep parametrectomy or DP2. Finally, we use the hypogastric fascia as landmark to define the type 3 deep parametrectomy, when the procedure was deeply and lateral to the fascia. So, for example, in this case, in European, what kind of parametrectomy is? We have a nodule on the uterosacral ligament, posterolateral parametrum, which we encompass the persacral fascia that cover the ureter and the right hypogastric nerve. In this case, when I perform my parametrectomy, probably I describe a deep parametrectomy type 1 because the nodule overcome the prosacral fascia. In this image, I see a nodule and then the medial rectal artery, and caudally to the medial rectal artery with a arrow, I see two branch of the inferior epigastric plexus that pass through the lateral ligament of the rectum and go to the rectum. In this case, if we overcome the medial rectal artery, became a deep parametrectomy type 2. In this case, in which I can see in the left epigastric nerve, the inferior epigastric plexus that is covered by epigastric fascia. If we overcame the epigastric fascia, became a deep parametrectomy type 3. So we see three landmarks: medial rectal artery, prosacral fascia, and hypogastric fascia. Sorry for this slide, there are too many words, but it's to explain you the kind of workup, preoperative workup. Typically, before the surgery, every patient try to one progestin, such Denerges, norethistérone, or desogestrel. And before surgery, each patient underwent a rectovaginal examination, transvaginal dedicated examination, or MRI. If we have urethral dilatation, we ask for UroCT or UroMRI, and obviously angioscintigraphy. In case of suspected compression to the sacral plexus or other somatic nerve, neuropelviological evaluation was conducted, but what does it mean? We try to study the dermatomer of the patient in which have apraxia or pain or other symptoms. We ask for electromyography and urodynamic test in some selective cases. For each patient underwent to this kind of surgery, we additionally we conducted a pain symptom interview, and we required GCLI, CAS, BIFLUS, and FSFI questionnaire. So go directly to the result of the study to understand what is my trip. The bladder volume deficit of the patient underwent to parametrectomy, that is in our series is 189, is the 9.7%. In the first classes of parametrectomy, we have a 3.4%. In the DP1, that is the parametrectomy that overcome the prosacral fascia, we have 17% of patients with that required self-catheterization till 1 month. And we have a significant statistical difference compared to the patient underwent to DP3 that have 13%. We have definitive autocatheterization over 1 year, in patient over 6 months, sorry, in one patient in a group of underwent to superficial parametrectomy, and one patient went to the deep parametrectomy 3. But why we have a complication with this kind of complication in a patient that have also a simple parametrectomy or superficial parametrectomy? Was the patient that had 7 surgery before the last one. So I was the surgeon that make the complication. About the neurolysis, we have also different significant different data. We perform ureterolysis in 10% of patients underwent to deep parametrectomy 3, and 14% of patients in deep parametrectomy type 1. 0 in the superficial parametrectomy, 0 in the deep parametrectomy class 2. That is the parametrectomy that goes down caudally to the middle rectal artery. We perform nerve ablation of inferior epigastric plexus, monolateral, or hypogastric nerve in 10% of patients in the right side for DP3 and 20% of patients of the left side in DP3. So about the functional outcome and the pain, we have an improvement in all cases. But about the questionnaire that evaluates the functional outcome, we have an improvement only about the case. And if we try to understand what class have the better improvement in the case, is the DP3. The only class that have a significant difference is that one, that obviously compared to the baseline after 6 months of follow-up. But another interesting case is that in DP2, is that the only group of patients in which we don't have an improvement, because we have an improvement in superficial, also if it is not significant in DP1, but in DP2, we don't have an improvement, but it's worse the result after the surgery. So we pass from a value high to the low value to the high value that describe the worst outcome of the case questionnaire. But why? Obviously, because we go down to the caudal, to the middle rectal artery, and probably we injure the part of the plexus that go and pass through the lateral ligament of the rectum. So summarizing, in our study, the extension of the parametrectomy laterally to the presacral fascia was linked to the higher incidence of bladder void deficit. In our result, not demonstrate a clear improvement in postoperative bladder function, with the exception of the DP3. But probably in this case, we have a bias because the DP3 is the group in which we have more patients that required self-catheterization. So it's strange that we have the best improvement in the postoperative bladder function described by B-fluids. Probably the bias is the low number of procedure in this group, only 10 patients. We have an improvement over time in the case in all parametrectomy, except for the group DP2, but probably for the lesion during the surgery of the part of the plexus that go through the lateral ligament of the rectum. And the parametrectomy, also in this case, underlining the result of the paper published from 21 to 24 of our group, not lead to a concurrent improvement in sectional function, probably for a injury of the part of the ortho and parasympathetic fibers that run near to the vaginal vein and artery. I think that this is the more interesting part of this paper, that is the criticity. Our group during parametrectomy, neurolysis of parasympathetic or somatosensory nerves was required in less than 5% of patients, while approximately the 6% necessitated to selective neuroablation of hypogastric nerve or component of the inferior hypogastric plexus. But this result appeared to be in contrast with the data of Chiantera that published in 2018, in which 35% of patients with parametric infiltration had simultaneous infiltration of the sacral plexus or the sciatic nerve. But probably we can explain this with the scales of Vito Chiantera, that is in 2018 was one of the surgeons that probably operate more patients with deep lateral infiltration of the somatic nerve. So we can define a third reference center in a period in which there are few surgeons dedicated to neuropelviology. Another data interesting of our paper is that 15% of DP3, the parametrectomy 3, required neurolysis of the sacral plexus, obturator nerve, sciatic nerve, or neuroablation of the hypogastric or hypoglossal plexus. But only 30% of the patient subsequently required subcatheterization. That is the data that are superimposed to what Roman reported in 2021. But one hypothesis to explain this data is probably the concept of non-dominant hemipelvis. In 2000, NEC described that right hemisphere language dominance increases linearly with the degree of left-handedness, suggesting the existence of a dominant hemipelvis from a narrow functional point of view. So probably this hypothesis could explain why surgical lesion or compression due to the condition like DA may not consistently result in severe functional damage in each patient of the study. So in closing, I want to show you a video that summarizes our classification of parametrectomy. Is a trachelectomy for a patient with a history of endometriosis treated in a non-radical way. And in 1991, she underwent to monolateral salpingo for endometriosis of the ovary, right ovary. We see with the MRI and CT scan that we haven't lymph node bulky. So we decide to underwent to surgery to confirm or less the risk of cancerization of the pelvic mass. We start with the usually ureterolysis. We found omentum adherence. We found the adherence with the ileum and abdominal wall. And then we see the Douglas pouch, in which we have 2 spots of superficial endometriosis. Then we collect the liquid for cytology, and we perform our adhesiolysis to understand where is exactly the mass and which is the really exposition of the parameter. So we decide to perform also, obviously, ovarectomy because the patient was in menopause. And we start our adhesiolysis as usual after the visualization of the ureter. Usually start from the left side. We decide to start from the promontory, and then we push forward to develop a part of medial pararectal space, and then pass to develop the rectovaginal space to understand if the rectum is attached to the mass. Here we can see the 2 fascia that cover the rectum, that is the fascia propria recti, and the fascia that is attached to the vagina. So the first step is the identification of the ureter, in which we can see the first landmark, that is the presacral fascia that cover the ureter. Then the procedure required ureterolysis because the ureter was attached to the pelvic mass. So we try to spare as much as possible the presacral fascia, that is the fascia that covers the ureter, or is also called the mesoureter. But before to perform the anterior parametrectomy, we try to detach the pelvic mass from the parametrium. So we expose, obviously, the left hypogastric nerve and continue our dissection, developing obviously the medial pararectal space till we see the hypogastric fascia, that is the fascia near the thunderbit. So we see the fascia, that is our landmark for the parametrectomy type 3, the hypogastric nerve, and the splanchnic nerve. Then, after the visualization of this part of a ortho and parasympathetic fiber, we can perform parametrectomy, understand what is the amount of fiber that that are attached to the mass. In these cases, was a nerve sparing procedure because we see and lateralize the fiber. Then, before finishing our left ureter lysis, we decide to develop the cervical vaginal space that is useful to understand and preserve the juxta vesical part of the ureter. That is the part that is required to develop the full space of Yabug. In this case, was not required, but it's important to understand where is the limit between the ureter and the juxta vesical part. So we lateralize and then perform anterior parametrectomy. So in this case, we can see two landmarks and the structure that are covered by the landmark. That is percecal fascia and the hypogastric fascia. If we try to spare this this structure, we can do a nerve sparing surgery. But in this case, we perform DP1/DP3 because we reach and remove a part of the percecal and hypogastric fascia, but we didn't resect the inferior hypogastric plexus. Then we finish with a vaginal cuff incision and obviously the vaginal cuff closure. The histologic report cancerization of a nodule of endometriosis with the endometrioid histopathology architecture. And the anatomo, our colleague don't show exactly if we have a case of relapse of the ovarian cancer, low-grade ovarian cancer, or a truly cancerization of a nodule of endometriosis. But probably the second the option is probably more true. So we haven't complication because as we see, we follow our landmark and we have a 15 millimeter blood loss. Thank you for the attention. Thank you for the invitation. Thank you for the time and the opportunity to participate. So important event like the webinar of the European Endometriosis League.
Mikkel, you're muted.
Mute myself. Yes, I'm on now, hopefully.
Yes, you are.
So I think, Manuel, this was a very good presentation of a very difficult topic, actually. This is difficult anatomy. This is certainly difficult operations. And I think the biggest problem for me is that the disease messes up the anatomy. So sometimes you lose your way finding your anatomic structures, and your removing of the nodule will remove part of the nerves. I mean, sometimes this disease itself is located, so you will get lost. How do you think we can solve this problem at all? I mean, in a cadaver, it's easy enough. There's no endometriosis.
I think that there is a beautiful paper of Roman and Darwish in which they say that probably the nerve sparing technique for endometriosis doesn't exist. Probably it's true, but we try to spare the ortho and parasympathetic fiber, like suggested by Serracchioli and Mohamed and Nuselio. There are a paper in which they suggest to stay medial to the fascia that cover the hypogastric nerve. So we have landmark. The important thing of this kind of paper that I present is the anatomical landmark. It's not the technique of nerve sparing, because it's not the topic. The topic is that you can try to describe your kind of parametrectomy using landmark. And the presacral fascia you can find in every kind of surgery. Also, after 3, 4, 5 surgery for deep endometriosis. The same is that for the hypogastric fascia. And obviously is the same for the middle rectal artery if the patient don't have obviously a previous low resection of the rectum. So I know your doubts. I know perfectly, but you can find your landmark and try to do a nerve sparing technique surgery.
I'm not saying that I have doubt. I'm just saying this is difficult. I think your presentation was very good. I think your screenshots and your movie was very good. But I mean, I had a patient yesterday where the nodule was surrounding the hypogastric nerve. And then you need to transect the area, and the disease will decide for you what possibilities you have. I think this is the tricky part.
But usually I think that is a true important, the counseling to the patient. If the patient decide to do the surgery for the pain, I try to push my surgery to the radicality. And overall, if I have a localization of endometriosis over the somatic nerve, also in one of the cases that I show you, the question is, I try to risk to damage the nerve, and I wait for a lapse of the symptoms, or I try to go directly in one-step surgery. Because in my opinion, if the patient decide for the surgery for pain, you have to try to be radical. Also, in case of risk of damaging the orthoparasympathetic or somatic nerve. Obviously, there are the limit, and the limits that you decide is a choice before your surgery. So in these cases, I present neurolysis, but also ablation of the nerve.
And I think this is very important, that you have to try to decide with the patient before you operate, how aggressive are you going to be? But you cannot, prior to surgery, it's so difficult to split up her symptoms in small sub-symptoms. What is due to maybe affection close to the sacral nerve roots? What is due to affection of the hypogastric nerves? What is due to the bowel nodule? It is so complicated to make the correct deal with the patient. What do you think, Mabrouk? Isn't this one of our biggest problems?
I totally agree. And here, if I can have a comment, because we have colleagues who ask a lot of questions, which means that they are very much interested in the topic. Thank you very much, Manuel, for the fantastic, very comprehensive talk. Here, if I can summarize or just take home messages for me, for my learning from your talk is, first of all, we need to pay attention that parametric endometriosis is not something easy. It is something that has to be taken with big exceptional consideration. If we suspect it clinically before the surgery by examining the patient, if the patient has persistent pain despite repeated surgeries, etc., we do an MRI. We have a suspicion of deep endometriosis of the parametrium. This is something that if I'm not very much skilled, I would refer the patient to someone who is. So I think this is the first big take-home message from you. Second take-home message is, and this is a question from the colleagues, there is no specific, as Mikkel was just saying, there is no specific symptom for the parametrial involvement or the bowel, because you can see many cases where we receive referrals for patients who removed or did a subtotal hysterectomy because, yes, she didn't have bowel symptoms or she didn't have ureteric symptoms or. When the patient has pain, we operate aiming at removing endometriosis. Now, counseling is extremely important. You counsel the patient, you agree with the patient. The question here is when to stop, Manuel. When would you stop? When would you say, no, I'm not doing bilateral D3 parametrectomy, for example, DP3 parametrectomy? I enjoyed very much the results of the tables that you presented, and there is a lot to take home from the numbers that you presented, also because they're very big series. This is a very big series. In your opinion, when would you stop?
Moment is the question that is the hard decision maker before surgery, because I try to talk with the patient and try to explain what is the percentage of complication. But overall, I try to understand what wants the patient.
Sure.
If a patient try to stay free of symptoms, pain symptoms, I try to push my surgery and push. But the patient know that probably for the rest of life, she need of autocatheterization on the sacral stimulation implantation. So we decide together. I try to understand what is the request of the patient, and I try to do my surgery. But overall, I try to understand what should be my complication, what kind of complication I do to the patient, and I try to understand if the patient can accept this kind of complication. I take my decision with putting together the decision of the patient, the desire, the level of the surgery that I can offer, and obviously the risk of recurrence after surgery.
Perfect. We will leave the floor to Mikkel because there are some questions in the chat box from other colleagues.
Yeah, there is one here that is very good. If there's a bilateral parametrial endometriosis, is there any way to detect which side is dominant before operation? Which side should you? I mean, if it's bilateral, it's like tossing a coin, I think.
If I decide to do a bilateral parametrectomy or not. Sorry,
that is one. But the question is also regarding: can you diagnose which side is the dominant? I don't think we have any test for this, do we?
No. I try to speak this issue with the radiologist, because with the MRI, functional MRI, we try to understand what is the hemisphere that is dominant. We can do with the simple thing. For example, if you try to do the piece during MRI, the part of your brain that govern this function is more active, but is impossible to understand exactly what is the dominant hemipelvis that control this the woman. It's not possible.
No, I don't think so. There is a question.
I have a
Specific
question.
questions to your results in the paper. One here is asking, how do you explain the improvement in DP3 operation, even though you injured the inferior hypogastric plexus in the type 3 surgery?
Probably with the question of with the issue of hemidominant pelvis. Probably depends by the fact that I make the injury, or I decide to resect the right side or the left side in case of a patient in which the hemidominant pelvis was the other. So I do 50% of ablation in DP3, but I have only the 30% of complication. So
Yes.
probably depends by the question we discussed before.
Manuel, I have a quick question. From your table, there was statistical relevant. There was just an improvement of the KES score, if I remember well, for the DP3, right?
DP3, yes.
And for DP1, DP2, and superficial parametrectomy, there was no statistical relevance in terms of improvement of KES, Kigley, FSFI, and so on.
Yeah, we have not significant improvement in superficial DP1. We have a worst result in DP2 about the KES. It's the only group in which we have a worst result after surgery. Probably because we remove the nodule caudally to the middle rectal artery, and we remove a part of the plexus that go to the lateral ligament of the rectum. Probably depends on this kind of complication.
I think this is an important takeaway message to add to Mohammed's list. Whenever you have to go for a DP2 type parametrectomy, you might get worse post-op results than pre-op symptoms, right?
Yeah, but I think that I want to thank Mohammed for the key point, to the key take-home message, but I want to add another take-home message that is about the useful of a classification. You can be agree or not agree with the decision to choose 3 landmarks, but it's too important that we talk about the same language. It's too important, because if I write a paper and if Mohammed write a paper at the different, we have 2 different results, is not depend by the skills of Mohammed or Manuel. Probably there are some different in the definition of parametrectomy.
I totally agree. I totally agree, Manuel. And this is what you presented is a very good anatomical classification. And I would personally, even if it's not one of the classifications for endometriosis like the NCN, I would suggest this to be absolutely utilized, because your parametrectomy, especially when speaking about the posterior parametrectomy, the lateral parametrectomy, is totally different. I mean, it is, and the results and the patient counseling and the data and the outcome, function outcome, etc., the DP1, DP2, DP3, SP are totally different. And again, this will be different in the publications and in every outcome. The only thing that I'm just thinking anatomically about it is DP1 and DP3, it's about the lateral extension. DP2 is a caudal extension. So I was just expecting you, you know what I mean? Usually when you expect a graduation, something gradual, DP1 to be here, DP2 to be there, DP3 to be here. But yes, I also understand where you're coming from. It is dependent on the functional, not only the anatomical outcome, if that makes sense. Do you agree?
Yeah, absolutely. Obviously, you should have a deeper nodule that is deeper, caudal, and lateral. So the definition is not too easy. But also for the case of the canceroid pelvic mass, we have a lateral extension, but probably if I do some kind of injury, probably my injury is down to the middle rectal artery because I go down lateral, but under my view, but down, I didn't see my landmark. So you can have a flexible way when you perform this kind of surgery using using the definition of parametrectomy. It's not static. You can say I perform a superficial endometriosis parametrectomy when you have a nodule that is superficial and you know and are sure, but you go down and lateral is more difficult. So the only landmark, in my opinion, is that one, middle rectal artery, presacral fascia, hypogastric fascia. I try to use the classical landmark that is deep uterine vein, but see the deep uterine vein also if you are a good surgeon in endometriosis surgery is more difficult than to the surgery for cervical cancer. It's totally different.
I think all this talk about classification is very important. I mean, we miss it in a lot of endometriosis operations. We compare apples and pears in a lot of our publications in general. So this is very welcoming. But I think this is something that you do during the operation. You cannot do this prior to operation. We will not have MRI scans that will tell you if it's going to be a DP2 or DP3. Do you agree?
In my opinion, you can use your visit. The rectum vaginal examination helps us to understand if it probably is infiltrated the half part of the parameter, the third part, cranial part. So when I start to study this kind of parametrectomy, I decide to change my counseling to the patient. After my visit, if the patient has a nodule on the uterosacral ligament, I don't explain the risk of neurofunctional damaging that I can have with another kind of patient. So I try to divide also before the surgery. You can do with your rectovaginal examination if you are sure, or with the MRI. Or also we describe with Antonia Testa, a paper which we try to describe anatomically with the sonography, step by step.
Yes, there are data coming up now locating the sacral nerve roots in ultrasound, and but maybe the endometriosis actually does not very often, in my opinion, grow into the sacral nerve roots if the fascia is intact. It's sitting on top of the fascia and putting pressure on the sacral nerve roots. It does not grow into the nerve roots.
So yes, may I suggest one thing before just before in the preoperative workup, the extension, the lateral extension, honestly, to the fascia and to the sacral nerve roots is something that you can see, and you saw the differentiation between D1, DP1, and DP3. I think by MRI is not very difficult, and also because the ureter is in the middle. And if you see that the extension, the lateral extension is till the presacral fascia, then you understand where you are. If you see more lateral extension, then this is a little bit more complex, and it's a DP3 rather than the DP2 is the one that I'm not sure if with preoperative imaging we will be able to. But I think it's also enough to understand if you're facing a parametrectomy, which is, let's say, not very complex compared to a parametrectomy, which is a really complex and challenging. Do you agree? Preoperatively, lateral extension MRI can show you the extension to the pre-sacral, pre-hypogastric fascia. Do you agree?
Yeah.
At
I
least
think
at least the pre-sacral. I don't know with the hypogastric. We looked at pictures today. Because the patient we operated yesterday was not diagnosed correct. I thought it was difficult to look at these pictures, and they were only 8 weeks old. And I think my MRI doctor is very good.
probably the MRI don't see the fascia, but MRI can see the muscle and can see other landmarks that are the vessel. If you use vessel and muscle, obviously we are talking about 3 millimeter, 4 millimeter, 5 millimeter. So it's nearest.
Yeah. There was one question saying that if you had, or this was maybe not a question, but more like saying that if you had an increased number of cases, you would probably find a difference being larger between your groups. And I think this is correct. This was talking about bladder function and sexual life.
Sorry, but I don't understand the question about
the question. I can read it up for you. Thank you so much for a very detailed presentation. If I understand it correctly, you mentioned about there was no difference between bladder function and sexual satisfaction, or what we call it. On the other hand, case number is 10 for the DP3 group, so it might be related to the number of cases. You also mentioned that, I think. Probably if you increase the number of cases, you might find a difference.
Yeah, probably.
Yeah.
I'm agree.
So I think
if we don't have any further questions.
Sorry, I didn't hear it.
No, I was saying if we don't have any further questions, we could call this an evening for a webinar.
Yeah.
And we have to thank Manuel, Aline, and Mikkel, and everyone who prepared for this webinar. I think it's very, very good. Really interesting. So thank you all.
No, thank you for the opportunity that you give me, really.
Thank you very much, Manuel and Mabruk and Aline. Yeah.
Thank you, guys.
Thank you, guys.
Have a nice evening.
Bye.
Have a nice evening. Thank you, everybody. Have a nice evening.
Ciao.
Ciao.